Hello, my name is Gary Snipes, and I am a part of the Palliative Medicine Group at Spartanburg Regional. I would like to talk with you today about a new initiative in our system called Directing Your Life, an important part of which will be training medical providers such as yourself to have effective conversations with patients about serious illness when that is relevant. The post-acute division of our system received a generous grant from the Duke Endowment. The purpose of DYL is to design and implement a microsystem to improve the frequency and quality of advanced care planning among patients in Spartanburg County and in our healthcare system. This initiative will be running simultaneously out in the community, in outpatient practices under Medical Group of the Carolinas, and in the inpatient setting.
This Duke Endowment grant is going to make it so that we can educate all of our providers, physicians, nurse practitioners, physician assistants, nurses, and our office staff on having these difficult conversations about end-of-life decisions. We'll be able to move them past looking at it as an end-of-life decision as to a long-term treatment plan for whatever illness the patient has.
The main components of DYL include community engagement events, outpatient and inpatient staff training to provide support for this effort and a process to make this happen when it should, training for medical providers in having the medical advanced care planning conversation, when appropriate, will be part of this effort, and finally, information system support for documentation of these conversations and ease of access of the plans that are created.
I think training everyone top to bottom throughout this organization is going to be critical not only for the success of the Duke Endowment, but for our patients and our community. Everybody has a vested interest in this. We all live and we all die, and we should have the opportunity to do it the way that we want to, and the Advanced Care Plan helps us do that.
The Duke Endowment grant that Spartanburg Regional Health Services has been awarded, extremely excited about that. We've identified that is a hole in our training, and we're looking forward to bringing those skills to the primary care physicians, the physicians within the hospital, the physicians throughout the system on how to approach and have discussions regarding advanced care planning.
An advanced medical care plan is any decision made prior to need, delineating medical interventions to be used in the event of certain conditions. We think about this as having two levels. Level 1 would be important for all adults and would be mainly completing a South Carolina healthcare power of attorney, which would designate a proxy decision maker and possibly indicate the types of care desired. Level 2 would be for patients with serious illness or clinical conditions suggesting limited life expectancy. Second level includes Level 1, but in addition should include a discussion about clinical reality and goals of care, possibly leading to the creation of a more detailed and specific advanced care plan, or a physician orders for scope of treatment, or POST form. If you don't know exactly what the POST is, I will speak to that later in the presentation.
Discussing your care plan, your advanced directives, is a challenge for some people. It's a challenge for an individual who's trying to make those decisions for themselves, to know the right questions to even ask. Certainly in a time where there's just more and more advanced medicine, you need a clinician, and this Duke Endowment helps us get to the point where we can train our own and use these funds to educate ourselves in the best methods to educate each other. Anytime a person can participate and help their loved ones understand what their wishes are, and as a loved one to be able to honor those wishes, that roadmap is so important. It takes away so much doubt, so much potential guilt. It creates some clarity, and it helps us as caregivers honor the wishes of the patient, and for also the family to know what those wishes are and feel good about how the care is being rendered. That's tough to do when it's a difficult time, and I think it'll have a huge impact on the way care is delivered here in our community.
Why do advanced medical care planning? Well, there are several reasons. AMCP partially addresses many of the things the evidence shows that people want at end of life: not to suffer, not be a burden, to strengthen relationships with loved ones, not have life prolonged unnecessarily, and maintain control to the end of life. In addition, most do not want to be in a hospital setting when they die. Sometimes aggressive care, the default path, may be harmful if people have reached that tipping point for their disease where more interventions result in poorer outcomes. And presently, conversations about serious illness are just not sufficient to the need. What if providers do learn and utilize serious illness conversation skills? Well, we get better, more effective conversations at an appropriate point in the disease trajectory. This impacts positively on patients and families. And yes, there are cost reductions in care at the end of life.
One of the most important benefits patients derive by having the discussion of advanced care planning is control. There are a number of reasons for all providers to have some comfort and familiarity with advanced care planning. Probably one of the most important things to remember is patients ultimately and their families will really be appreciative of the discussion at some point. Those visits, I have found over the years, are far more important than perhaps sitting down and discussing further treatments. If you can have that discussion at a time when they're in the office, there is no threat, there is no crisis, you can have that discussion based on a patient's wishes, you can provide your patients and families with huge opportunities that can really be a blessing.
Which patients should do advanced medical care planning? All adults should have level 1 planning, but a risk-stratified approach makes sense to identify those whose medical conditions warrant more in-depth discussion and planning tailored specifically to them and their goals of care, what we call level 2 AMCP. And who should support the creation of an advanced medical care plan? For level 1, lots of people: office staff, nursing staff, case managers and chaplains in the hospital, AMCP facilitators in the community who would be volunteers. Also, it can be do-it-yourself by patients, particularly with online support through MyChart. Level 2 includes level 1 planning plus the conversation with a medical provider to determine goals and plan of care. Why should this be a medical provider, meaning a physician or an APP? Because these conversations involve developing with patients and families a plausible explanatory model of clinical reality, usually a prognostic prediction of some sort, and a recommendation on a reasonable medical plan of care under the circumstances. But medical providers do not need to be involved in most document creation once the conversation is done and the plan is made. And what are we trying to do here in this training? Our intent is to teach medical providers the most effective way to have basic advanced care planning conversations. Now, the evidence shows that many patients want to have these conversations if given the opportunity, and are not resistant to them. But we are not trying to turn you into palliative medicine specialists.
So having that conversation both with my dad and with my family and his doctors helped make a lot of the decisions easier. There were no questions. When he was actually actively dying, he was doing it at home. We knew exactly what his wishes were. There was never a question about what he wanted or what he needed. We knew. We had the support that we needed. The advanced care planning provided that, so it gave us the guidance to do what he needed. The family knowing what his wishes were made it easier on all of us. There wasn't any wondering. So it made us come together more as a family and grieve together more than wonder or not know what exactly he wanted. It made that grieving process just a slight bit easier.
Hard cases, resistant cases, you may need to back off for the time being, or these may be the patients who require palliative care consultation and that level of team support to make effective decisions. There are many barriers to these conversations. Many clinicians lack communication competency because it was not taught to them, but many also don't know that. The culture of medicine does not value key elements of effective care, such as advanced care planning discussions. While we may lament it, we accept late or non-existent conversations, realizing it is a low priority and there is little accountability for having done this at all or done it well. Poor end-of-life care is tolerated by default. Finally, our focus is on avoidance of the messiness and time-consuming nature of these discussions, if possible, because we are all under time pressure. So why have these conversations then? Well, when they are needed, it is the right thing to do. And not having the conversation can result in unnecessary suffering due to useless medical interventions. Simply put, having these conversations at the right time can result in better outcomes of care, something we are all interested in.
It's very important for providers to learn about advanced care planning. Providers that have developed a relationship with their patient in an office setting, there is a trust factor there, and it allows a deeper understanding of the patient, allows the patient to have time to ask specific questions, and really come at an appropriate treatment plan considering their overall medical status. The concern obviously is whether you're not making the right decision for that patient at that time. Advanced care planning in critical care it's one of our core duties, and we take it very seriously. It's so much easier if the advanced care planning discussion has actually been had with the patient by their own physicians in the physician's office. Times when there's no crisis, because at times of crisis, people tend to make decisions that are really not aligned with what their true beliefs are.
How this works best is illustrated by this graphic. The basis for shared decision-making is a relationship of trust with the patient and family. Throw in medical information that provides a plausible explanatory model and a discussion about what is important to all involved, and this results in effective collaborative decision-making. Let's talk about the Directing Your Life Conversation Guide. The guide is an adaptation of the Ariadne Lab's Serious Illness Conversation Guide. It is a checklist and can be used as a script, particularly while providers learn this method. We will teach you how to use it through both didactic instruction, this video, and on-site skills training, and we will provide phone support and additional video instruction after the initial training, because you will encounter some dilemmas if you have these conversations regularly. On that note, I would urge you not to get stressed out over difficult conversations. Some folks are just not ready to confront clinical reality, even with the best of communication technique, and simply need more time to adjust. Even for the most skillful medical communicators, these can be challenging conversations.
Advanced care planning is extremely important, if not essential, in many of our patients. When it comes to families and having the advanced care planning discussion, they really benefit by being relieved of that burden. Invariably, what happens too, if you have a large family, is you can't get people to agree. You have a patient, let's say a 70-year-old gentleman who's got advanced lung cancer. The wife isn't ready to let him go, but there may be 2 children who are at peace with it, and a daughter and a brother who aren't, and so then everybody's sort of struggling with what do you do, what decision should be made. And the truth is it shouldn't be the wife's decision or the son or the daughter, it should be the patient's. What does the patient want?
These are the components of a well-conducted serious illness conversation. Respectfully set up the conversation, assess the patient and family's current understanding of clinical reality and their preferences for receiving information, share medical information, which often includes a prognosis of some sort, respond to emotion if it occurs, explore the goals of care under the circumstances, summarize and make a recommendation, and sometimes complete a post-form collaboratively with the patient, though that isn't always possible. This is the conversation guide that we will teach and that we recommend you use while talking to patients. It will be available to you in a number of formats, both paper and electronic. There are some general communication tips that we find useful. Always sit down if at all possible. Use Ask, Tell, Ask by asking a leading question early in the meeting and allow people to talk some in order to engage them. Be fully present and listen attentively to what is being said and conveyed in verbal and nonverbal fashion as well. Meetings go best when the provider speaks less than half the time. Be authentic, as though you were talking to your own family. And be comfortable with some silence if patients need to collect their thoughts. The first step is to set up the conversation for success. I'd like to talk about what is ahead with your illness and do some thinking in advance about what is important to you so that I can make sure we provide you with the kind of care you want. Would that be okay? I will be using a guide so that I won't forget anything important. The purpose of this is to set the agenda with permission from the patient. State the benefit. This allows the patient to stay in control. Ask permission to use the guide as you speak. It is important to develop a shared understanding with patients of clinical reality and to know how much information the patient really wants. There are two good questions to do that. What is your understanding of your current medical situation? And how much information do you want from me about what might be ahead with your medical situation? Remember to ask the question and then give them time to answer. Their replies will shape the information you provide to them subsequently. Once you know what the patient and family understand, it is best to then share your story of their illness in order to give them a plausible explanatory model. This may involve disclosure of a prognosis, which is a prediction about what the future may hold for them. In certain situations, such as advanced cancer, this may entail a general life expectancy expressed as a range of time. In organ system failure, such as COPD and heart failure, it can be helpful to explain the ups and downs of these conditions as time goes on. And in frailty, dementia, or other neurodegenerative disease, prognostic disclosure may be an acknowledgement of uncertainty of the time frame, while making them aware that there will be continually worsening function and overall health status as time goes on. With prognostic disclosure, you often elicit emotion. And what should you do about it? Almost nothing you say can fix it, so often just being present in silence is best. If you feel the need to say something, the nurse protocol does give some guidance. Here are some examples of statements that may be helpful. Name the emotion. I can tell that thinking about your mom's decline is making you feel sad. Understanding what they are going through with this statement. It must be really hard to see Jane go through this. Show respect for their journey. You both have worked very hard to turn things around with this cancer. Commit to support them with a statement such as, whatever you decide, we are going to do everything we can to help you get through this. If emotions seem to be overwhelming, explore what may be driving the emotion by saying, tell me more about what you're feeling right now. There are a number of questions in the guide designed to determine the goals of care. Which ones you actually ask depends on the situation and what feels right to you as you go through it. Some example questions include, what are your most important goals if your health situation worsens? Or if the patient seems anxious, asking, what are your fears and worries about the future with your health? May be useful. Sometimes establishing thresholds of acceptable performance or determining willingness to endure more treatment burden for a bit more time is helpful to establish. Finally, if the family is not present, it is good to know what has been discussed with them. To conclude, it is good to summarize what you heard from the patient about what is most important. For example, it might be something like, "Mr. Jones, I hear you saying that the last few months have been very difficult with many hospital stays and continually declining health. You have indicated that you would prefer to focus on feeling as well as you can for as long as you can and being at home with your family. Is that correct? If your understanding of goals is confirmed, this is a good time to make a recommendation as far as a reasonable plan of care, with a statement such as, I would recommend that we make it clear in your advanced care plan that you do not want life support instituted and would prefer to have your care at home and avoid the hospital. It would be good to discuss with my staff what systems of care are available for you at home too. Does that sound about right?"
None of us want to talk about death. None of us want to take that subject and deal with the uncomfortableness. It is a difficult conversation. I did not want to talk about that with my mother, but at the same time, out of respect for her, it's a necessary talk that we have to have. With respect to my mother and her diagnosis, we knew that eventually her cancer would be terminal, that she was beyond a treatment at her given age when it occurred. So we had to come to an understanding of what were her wishes. What did she want to have treated? How much treatment did she want to have? At what point do we move from treatment to palliative care treatment? And then at what point do we move from palliative care treatment to hospice care? All of these steps are treatment of the patient, and all of them involve respecting the patient's wish. And in my mother's case, it was a very easy transition because we had that conversation early.
What documentation would you need for this conversation? Since the post form is now available, it will be the most effective document. As the provider, you will need to document the discussion for the record and for billing purposes. We have created a template in Epic for that, and we will provide a tip sheet for its use at the on-site training. This is the Physician Orders for Scope of Treatment form. It has been passed by the legislature, signed by the governor, and is now available for use. We join over half the other states in having such a process, and it has worked very well throughout the country. We will be providing training in the post process through a companion video that will be available on HealthStream.
Caregivers have to understand the importance of advanced directives because our goal is to take care of the patient. And if the patient has a specific goal, outcome, or a way that they want to be treated, we need to respect that. The sooner we can begin that discussion, the sooner the patient can be involved with it, then the sooner we'll be able to get it down in writing into the medical record so that there'll be no question when that time comes.
There are 2 codes you may use for advanced care planning services, depending on the time spent. This can be billed multiple times and may be used in addition to other E&M codes, both in the outpatient and inpatient setting, the exception being critical care units, where advanced care planning is considered to be bundled into the service. There will be a tip sheet in your packet in the on-site training with more information. I have had concerns expressed to me by providers about how long these conversations take. The Ariadne Labs data shows that it is about 20 minutes on the average, a bit more than the typical 15-minute slot in an outpatient practice. For many of you, workflows may be best served by scheduling these as a separate appointment. and we will be discussing possible approaches with the support staff. I appreciate you reviewing this video and for participating in directing your life. The remainder of the training will be skills training using role plays as painlessly and effectively as we can make them. Thank you very much.